Today's episode of the Gestalt Education Show is brought to you by three of our favorite sponsors: Human Locomotion, Core 360 Belt, and Dynamic Disc Designs. All the information can be found below. By now, you have definitely heard us talk about them, so check out the show notes, click the links, use the codes, and make sure you support our favorite people. As always, we got a great episode lined up for you today, and thanks for tuning in. All right, everyone, welcome to another episode of the Gestalt Education Show. Today we are making our way to Kansas City, and so if you're listening on YouTube, this is a non-video because, well, we're literally in the car driving, Brett, so we're taking this podcast literally on the road. So we've kind of had a hectic schedule lately, so we figured we got a couple hours here on our way to Kansas City for the MPI Adjust-a-thon. We might as well record a podcast while we're going. So today's episode, we're going to kind of debrief on the Dr. Anthony Romeo podcast that we did that was released a couple weeks ago, and kind of give our perspective on it. And, you know, it was an amazing conversation. I mean, that dude is an absolute savage and just a great human being. I mean, we literally spent, I don't even know, 4 or 5 hours at his house with his family, which, by the way, the house is pretty impressive. But he's just a good dude. And I think that is kind of like reflected on all these like high level, big name orthopedic surgeons we've met. Like, none of them really have that big of egos, which was kind of, well, not what I was expecting. I don't know about you, Brett.
Yeah, no, he was awesome.
Yeah, and so obviously we talked to him, and he is known for repairing the lat, and we talked a lot about that. But then, you know, we kind of also exposed that he kind of gets typecasted into being the lat guy, when in reality, he's got a pretty wide repertoire of surgeries that he's really known for, and his ideas on collecting data and building populations and making a difference on healthcare is actually really, really, I mean, inspiring, to be honest with you.
Well, and I mean, we had a lot of good conversations with him off camera about being typecast, because I feel like a lot of us get typecasted too. You know, you're known as someone who's into baseball, or maybe you're known as a hockey guy, and you know, sometimes the world doesn't know that you're doing all these other things, and you get kind of stuck in your niche. You know,
yeah, right.
So
right.
it's kind of it can be a problem, quite honestly, for some people.
Absolutely. Yeah. So, I mean, to start off with, Brett, I mean, obviously, once the lat is torn, you and I were kind of, and maybe I'm speaking out of turn with you, but me for sure, once I figured that the only option was surgery at that point. And so Romeo brought up some great points on actually non-operatively treating these patients and getting some pretty damn good results. And so I don't know, did that surprise you at all with this conversation about the non-operative?
Well, I didn't know they were grading the injury like that, and to know that, I think he said there was 4 grades maybe, and that 1 and 2 are conservative, and then, you know, beyond that, then, you know, you're thinking surgical. And no, that was kind of news for me. And I mean, it's always interesting for me to hear, like, when you're talking to the world's expert on a topic, especially in the world of surgery, how conservative they are. You know, you would think that they would be the ones that would be biased into doing more invasive procedures, but one thing across the board we've learned from talking to them is, you know, a lot of times they're more conservative than the typical run-of-the-mill surgeon.
Yeah.
So,
which I think is you know, a question we always get is, obviously we have a great network in St. Louis of orthopedic surgeons, but, you know, people always ask, how do you make relationships and stuff like that? I think that's one good indicator of a really good surgeon, of whether or not they are conservative, mainly because they're looking for their batting average, right? I mean, they're trying to have a really good batting average, trying to have good outcomes. But I think if you have people that are a little bit more conservative and willing to listen to you, then that's a pretty good idea that they're doing the right thing.
I couldn't believe also, like, he was so in for like best practices. And he was just, I just thought he, you know, had a really good message about always improving. There was no arrogance. It was always just like, you know, this is what we can do to be better. And I love the story too. When he did Jake Peavy, they spent the night in the anatomy lab. He was just wanting to be sure that, you know, he didn't mess anything up in the surgery. And I think, yeah, what a mindset. I just think, absolutely. I thought that part was so cool too.
Absolutely. And then one other thing that's been reflected on basically every single surgeon that we've talked to is, 1, the importance of the physical exam, but then 2, the importance of palpation. And so, you know, he talks about getting the length tension ratio right in the lat, which we, you know, I've always said has got to be just so damn difficult. But, you know, him talking about getting that right, and you know, it's such a feel and it's an art. And I thought that was a really good message too.
Yeah, I mean, the big tendon injuries, the reason they end so many professional athletes' careers because getting that length tension ratio right is so challenging. So after you rupture it, you can almost imagine trying to sew together two horsetails or two ends of a mop kind of. So the ligament structure, so it's so much easier to get that ratio right. And I feel like that's why like the Achilles tendon and the patellar tendon, they, a lot of times those are a death knell to a professional athlete because getting that ratio right is very challenging. So, and then if you look at the lat, I mean, it's basically the Achilles tendon or patellar tendon of the upper extremity.
Yep.
So that's why, I mean, you never want one of your athletes to get it. And that's why we just wanted to hear his perspective on it. And we didn't want to be rude and kind of jump in on our end of it. But we probably have a lot to offer these athletes, the prodromal phase before that actually happens. So, the thing that, we always think about would be what would be the things leading up to that injury. And I think really, I mean, you could simply do like a bilateral humeral flexion test to see if there's shortening in the lat. And we've taught a lot about the palpation there. And you will find in these professional pitchers, they have, it's hard to even call it a trigger point what's there, because it almost literally feels like a golf ball or like a plum in their lat there. And, if you've never felt it before, just start looking for it. You'll see it. And I think that a lot of those ruptures are probably going to be the people that are in that category before. So it'd definitely be worth checking in on. And I think that, it is an epidemic trigger point. Travell and Simmons talked about the upper trap, housing the most common, trigger points in the body. I'm telling you, when you start looking and feeling for that trigger point in the lat, the overhead athlete, it is there. And then the interesting thing is, just like in the hamstring, people typically, they don't tear where the adhesion and where the trigger points are. Hamstring's a great example. Like all of Travell and Simmons' trigger points are more in the distal part of the muscle, kind of around the superior to the knee. And the lat is going to be the exact same example. So you can almost imagine it like a rubber band where, the part that is adhesed isn't the problem. The part that ends up breaking is higher up. In the hamstring, we have all our injuries up by the ischial tuberosity. And you're going to see the same thing with the lat. So almost, we call it like intramuscular imbalance, where within the same muscle, we're not able to have good extensibility. Therefore, we end up having our catastrophic injury a lot of times away from the site where the adhesion is, because you're the muscles having to do too much in those other areas to kind of compensate for the area that's unwilling to give.
Yeah, it's those musculotendinous junctions, like where those the blood flow is maybe decreasing a little bit, I think, and kind of where the tension is really being slacked. And I just think the lat too is such an interesting muscle. You talk about it a lot, Brett, that most people think about it just as shoulder rotator, but in reality, like, it's a low back stabilizer. It connects all the way down into your sacrum. Like, there is just crazy connections here. And so really the densifications or the tightness or the trigger points or whatever you want to call it can really happen all over. But I agree, like in the armpit or in that area where you're talking about that densification being, like, it is rampant, even in our non-athletes.
Yeah. So, yeah. And I think that, we go and do strength conditioning or we go to train. I think it is so easy to overcompensate with this muscle. And I always give the example of like the pediatric patient who is unable to even initiate a pull-up. So you're 8 years old, you haven't spent any time in a gym. We've all seen it when we were going for the presidentials in gym class. There's a kid that can jump up and literally bang out 20 pull-ups. And then there's even maybe the best athlete in the class gets up there and literally, if their life depended on it, they couldn't even initiate the pull-up. And so what ends up happening is the lat becomes like the ultimate like compensator, substituter, where even if they don't, have any rehab or therapy, now they're 20 years old, now they're in CrossFit, let's say, you can learn how to do 30 pull-ups through compensation without having the right activation. So what ends up happening is if you're not fixating your scapula in the most ideal way, you will just completely overcompensate through the the lat basically. And that is a real common thing that we see with people. And, if you're ever unsure what it should feel like, then the next time you're around a 10-month-old baby that's developing normal, flex their humerus, feel what that lat feels like, and then compare it to the athlete that's in front of you. And you're going to be like, wow, I literally cannot believe this. So that's like, you and I, we've really spent a lot of time in the Steco world. Of course, we're dry needling, shock waving these densifications, but I mean, we're also kind of humping that muscle with our elbow or our knuckle, because like you will feel like so much gunkiness there. And as much as a homer as we are for DNS, I mean, even with all the best DNS correctives, that soft tissue has been changed so much that, without manual therapy there, I don't think you can do enough corrective exercise to address that.
Yeah, I agree. I think even, especially when we talk about the musculotendinous junction, I've been finding a lot lately too that, like you talked about the quad tendon too, having that densification at the quad tendon. I just don't think that there's any other thing that can really change those other than manual therapy, and which kind of hurts my brain to think about, because if you have a trigger point in the trap or something like that, like you can get rid of that so quickly with DNS exercise and some other things, but the true like densifications in those musculotendinous junctions are just tricky to get rid of.
Yeah. And I think too, like when you're younger, when you have muscle imbalance, like you feel just more like tension in the overall muscular noise kind of. And then as that continues over time, you actually like histologically change the tissue. And I think that's where, the people is the pendulum continues to swing back and forth. The people that are in manual therapy really kind of, we hear them speaking out and saying, like there's still a need for, good soft tissue treatment. And I think that, having an ART toolbox or Graston or dry needling or shockwave or fascial manipulation, it's imperative for these entities that we're talking about right now, because corrective exercise, honestly, sometimes it's just simply not enough.
And I think it goes back to our whole principle of Gestalt, which is integration, meaning if you just get rid of the densification, but you don't reintegrate the musculature, we're a homer for DNS, then that densification is going to keep showing up, especially in our athletes, I think anyways. I don't know if you'd agree with that, Brett?
Yeah, 100%. And I mean, of course, we're blending the two. I mean, there's, for those of us who've seen a DNS seminar recently, especially the DNS baseball one, we talk about some of the positions from like the higher oblique, with sliders and things like that we use to treat this specific problem, but we're always mixing and matching that in with the manual therapy,
right?
So.
Which kind of takes us to our next point. I think we're both going to agree on this: the scapular dyskinesis or scapular instability. Call it what you ever want to call it. I mean, the scapula sets the stage for the throwing athlete or the overhead athlete, and so if you don't have the right interplay of the muscles around there, then you're setting yourself up to gain these densifications and then gain these other issues.
It's just such a unique part in the body, because you basically have a floating bone. You have a pseudo joint there, but the stabilization of that joint is so critical. And it's really not necessarily like a strength issue as much as it is like
coordination.
Yeah, coordination, being able to distribute the tone in the right way through all the muscles around the shoulder. And not that we ever wanted to specifically pick on one muscle, but one muscle that, is very prone to inhibition is the serratus anterior. So a lot of times we are doing a lot of our DNS correctives in an attempt to kind of bring the serratus anterior back into play. Therefore, the other muscles around the shoulder have an ability to not be overworked as much.
So then, Brett, what about some other compensations that maybe go along with this lat tightness? What else have you seen as far as patterns? When you find the densification in the lat, are there other things too that you're finding in the upper quarter that maybe correlate to it?
Yeah, I mean, I think like in a throwing athlete, like the people who have an unstable shoulder girdle area, like we usually find like a lot of limitation throughout all the muscles. And I think, there you don't even need like 5 tests to tell you whether or not they have an unstable scapula, because if you check their internal rotation and they have trigger points in their infraspinatus, if you check their pectoralis major and they have all 7 trigger points there, you're starting to, leading you to the conclusion that they're probably not stabilizing their shoulder very well. So at that point, like any more testing is just becoming redundant at that point. That's where, like, I mean, the soft tissues, they tell you a huge story as far as stabilization if you learn how to, palpate well. So of course, it's always good to reinforce with other tests, but I mean, if your feeling is, you can bet your bottom dollar that they're not stabilizing the shoulder blade in the most ideal way. And then, not to always bring everything back to intra-abdominal pressure, but, it's so important to have the right trunk stabilization through intra-abdominal pressure. Therefore, you're setting up muscles like serratus anterior and really, quite honestly, all the muscles around the shoulder girdle to be successful by the positioning of the rib cage. And I think that gets understated. I mean, because if you go to a seminar, everybody just wants to know, like, well, what are the best, scapular stabilizing exercises? But really, there is a key prerequisite, and that prerequisite is being able to stabilize your trunk correctly through intra-abdominal pressure. And the older I get, the more I come back to how important that step actually is. So I think that, and I think like sometimes it's a tired thought because we've talked a lot about it, but I do think it's like critical for setting up muscles like serratus anterior and honestly muscles like the lat, because if you don't have the right intra-abdominal pressure, we know the lat as being a humeral adductor, internal rotator, and shoulder extender. But from the other side, it is one of the most potent lumbar spine extenders on our body. I mean, of course, the paraspinals and erector spinae, but actually the lat through the thoracodorsal fascia is a major lumbar spine extender. So a lot of your patients, they also struggle with overutilization of the lat because they don't have the other attachment of the lat stabilized correctly. A lat pull is a great example. Like if you go to the YMCA and you see people doing lat pulls, for example, then what you'll see them using over recruiting their lat, but they don't have the attachment site stabilized in the correct way. So that's where, like, not that we're some huge proponent for machines, but even like if you are looking for like a land-based exercise, for example, like in a swimmer, then that's not a horrible place to start, because you start to train the central nervous system how to have that area stabilized in the right way. Therefore, the lat is a stable foundation to be able to pull from. We always use the example of like a backhoe, where you'd never like start scooping with a backhoe until you put the outriggers down and had stabilization first. So
yeah, and I think too, going back to your point on intra-abdominal pressure, if you're bought into the abdominal wall being a stabilizer, the thoracolumbar fascia would be included kind of in that posterior abdominal wall. But it would also be, if you're bought into the oblique slings, like from Fleming's work and those, and who am I thinking of? Anatomy trains.
Tom Myers.
Tom Myers. Like if you're bought into that idea, then the thoracodorsal fascia is vitally important when it comes to stabilizing in the posterior chain. So when you don't have the right intra-abdominal pressure, especially posteriorly, then it's very hard to then load the thoracodorsal fascia to create force transduction all the way through your body up into your shoulder.
Yeah, and I mean, if you think, these slings, they have literally been talked about. When I talk about a DNS seminar, I kind of tell the history of it. In the early 1900s, there was an anatomist by the name of Lovett who originally started talking about it. And then in the 1970s, there was McKinney and Logan. They were talking about it. Then we got to the 80s and late 80s, early 90s, and you have like the group out of Amsterdam, Andre Fleming, Oscar, Snyder's. They were, to me, they're the absolute real McCoys in all of this, because they were anatomically sorting all this out. And if you read Movement Stability and Low Back Pain from the first edition, which was in the 1990s, they have this all so eloquently dissected out. And I sometimes feel like they don't get enough credit for what they originally did. And then, of course, out of Italy, I mean, the Stecco family has done such an amazing job of enlightening us on all of this. And I think Tom Myers has made himself very famous by, exposing it, and good for him for doing that. I just feel like sometimes we forget to talk about some of these other
the origins.
And Andre Fleming, I've been lucky enough to to be with him a couple times. He is such a nice, humble man. And I think really, I mean, they were making this connection in the mid 1990s, and no one really talks about it. But you can almost imagine, like in the throwing athlete, you have an anterior oblique sling, and you also have a posterior oblique sling, and then in between that, we have this intra-abdominal pressure mechanism that needs to be at play. So, from an architectural and engineering standpoint, you have the most beautiful combination of forces that could. That need to be, thought of. And it's not just about utilizing and activating these slings. It's also about making sure you have the right extensibility in these slings. Because, we always use a rubber band or a slingshot as an example. If you have a massive trigger point, for example, in your lat, well, that is limiting the amount of elastic storage and stretch that you could have for throwing whatever the implement is. We're talking about baseballs right now, but all the throwing sports.
Yeah, beautiful. What about, Brett, joint system? So when you do find the densification in the joint system or in the lat, what are the joint consequences of that? Are you finding restrictions in certain areas or anything like that, or not necessarily? It's just kind of common, or what do you see the patterns in?
Well, if you look at the injuries in Major League Baseball over the last 15 years, one interesting trend is that even though we don't always 100% agree with what's getting done with rotator cuff strength and things like that, we've done a pretty good job. I mean, the reported injuries in the shoulder are way less than they were. So we have way more elbow problems, but we're having less shoulder problems. So something that we're doing is working. And then I think the surgeons, and Dr. Paletta talked to us about it on a previous podcast, where the really good orthopedists, they're not operating on shoulders as much as they were on the throwing athlete. Back in the day, you'd have pitchers that would have, for example, fraying of the rotator cuff, or even a partial slap tear, which, they were repairing quite a bit. And then they realized the results weren't so good. And as you can imagine, when you start suturing structures of the shoulder, you lose external rotation, which is, that motion is imperative for throwing baseballs at a high level. So they kind of learned that, we got to be kind of careful when we're tacking everything down, because we lose that critical motion. So, I think you have the same things that need to be utilized. I mean, we've all seen these cases where they're not stabilizing their shoulder blade well for whatever the reason. And I mean, we have very, very predictable joint blockages. The most common ones are obviously in the CT junction. It's been spoke about quite a bit in our profession of losing posterior glide of the humerus and the glenoid, which we see that not only on people who have overactive muscles like their lat, but their external rotators of the shoulder. In fact, the old school chiropractic move, which we're all taught, where we're basically, gliding the humerus posteriorly, that is probably not really an articular move. That is probably a way to get better extensibility out of the muscles in the posterior shoulder, the posterior capsule. So we've been doing this chiropractic move for 120 years, excuse me, and what we're probably doing is getting better extensibility in the posterior capsule, which is, the posterior capsule is just an extension of the infraspinatus and teres minor. So if we're finding tension in that structure, take a look more proximally, and you're going to probably find trigger points and soft tissue tension and tone in those posterior rotator cuff muscles also. But all of that is in compensation for not stabilizing your shoulder blade well.
Yeah. And then when you are doing the soft tissue on the lat, you prefer it supine?
I've played around a lot with it sideline too, with that side being up. What I don't like about it is I feel like the shoulder's kind of in an unstable position sometimes there, so I don't like it as much because of that. I will do it, but I find myself doing it more from a supine standpoint, really.
Yeah, beautiful. And then we kind of just touched on it, DNS positions that we do love for this, like modified low oblique sit or modified high oblique sit with the sliders kind of pushing outward.
Magical.
Really good for that. Any other ones that you really like?
I like going from a 3-month supine position, almost like a traditional pullover, but then coaching position of the rib cage, and then working lat extensibility with the right intra-abdominal pressure, or manually, positioning the shoulder blade down. And then you get a truer representation of how much extensibility is in the lat when you do that anyways. Otherwise, they just, through thoracolumbar hyperextension, when they flex their arms, you're just seeing all this excessive extension. So I think in, even in the gym setting, training with heavy, we'll just say like a 70-pound dumbbell on a pullover, like when you get done, if you've coached everything up that we just talked about, you'll see that will free that motion up, ironically, quite a bit, just from doing that. It's also like a really sneaky way to get better movement in your thoracic spine. Like if you play around with that the next time you're in the gym, a lot of times you'll actually release and cavitate the joints in your thoracic spine as you're, keeping your rib cage down and getting thoracic spine uprighting.
Yeah. And then one thing I stole from you is when you are checking humeral overhead flexion, when in a supine position, you do stabilize the rib cage in order to get a true representation of the overhead movement. So I think that's a great way to it's a slight pressure downward on the rib cage, and then you do humeral flexion. I think that's a good way. But then I've been using bear a little bit lately too, more like a pike position, and to get a little bit of eccentric load to the lat. So
bear is so nice, especially like we always talk about like how much we like low bear off the forearms, because it's just it's really difficult, I feel like, for the patient to mess that position up. So that always goes home really well. And I'm always just impressed with, like, if you're doing, some kind of auditing process after we've worked with the athlete, they're doing it at home, how that comes back in the office on, a simple bear exercise.
Yep. Sweet. Well, yeah, I think we've kind of touched on everything as far as the functional model, what it would look like maybe pre-injury, and then as far as post-injury, Brett, do you have any ideas on what that rehab process you'd like it to be like? I know Romeo kind of touched a little bit on what he did. He'd like it to be, but then once you have that repair, are you expecting there to be densifications longer term because you've shortened that muscle, and then are you going to use the same DNS positions as far as reintegrating the musculature, or maybe some different ideas on that?
I just think it would be critical to be sure that you come back and like make sure there is good extensibility. No different than any other orthopedic problem. Like a lot of times we'll surgically fix where the catastrophic problem was without addressing what the functional problem was, and then you're really kind of susceptible then. And if you follow some of these athletes out who've had this surgery, you'll also find that a lot of times they've had a Tommy John surgery, they've had, other procedures. So, the actual term that I really like, I call it like doing an autopsy, which is like if we could do an autopsy on Jake Peavy, after the fact, or even like before he ruptured his lat, you probably would have found everything that we're talking about, So that's where like you could kind of like insert, someone like ourselves in that situation where, if you're working with the same 25 people every day, you'd want to be paying attention to that, because there is going to be a prodromal phase you're going to find. And if you're not looking for it, then, and no different than like an Achilles tendon or even like a patellar tendon rupture.
Right.
And then not to open Pandora's box, but anytime you have big tendon injuries, you start to look at maybe some other things. You could be looking at metabolic problems. You could be looking at iron issues. You could be looking at undiagnosed celiac disease. All of these things could be one of the reasons why we don't have good integrity in our tendons, especially like if you're 20 years old and you have a big tendon injury. If you look hard enough, you are going to find something that's not perfect in the functional medicine side of that case. So, always being on the lookout for some of those like weird things that kind of weaken our tendons. And I think that's comprehensive care. And then the lat is just such a crazy, unique muscle. It's one of the unique muscles in the body that basically twists on itself. We see that in the pectoralis major. We see that in the levator scapulae. You see the Achilles tendon take a 90-degree turn as it's incentering in the calcaneus. And whenever you have that situation in the body, you're basically looking at an area that's having to deal with a lot of tensile force. That's why, like, if you get up real close to like the Golden Gate Bridge and you look at the cables, you'll see it's not just a cable, it's actually multiple cables that are spiraled together. So anywhere you see that in the body, you're looking at an area that's having to deal with a lot of tensile strain, and that kind of sums up baseball perfectly. But the really unique thing was you can't find this injury reported on before like Jake Peavy. So then next question is what is the problem? And I think, and Dr. Romeo highlighted this, we're back to velocity. I mean, if you are wanting an uptick in velocity, one area that you potentially be working on is these bigger, more superficial muscles or slings. So, which is totally fine. We should swerve into that and respect that. However, we also want to be sure that we have everything secured and stabilized through some of the more phasic groupings of muscles. That, of course, being the serratus anterior, the lower middle trap, and then we've already talked about pressurization, balance of the muscles around the rotator cuff. One thing to kind of look out for, too, is, a lot of our athletes are aggressively strengthening their external rotators, for example. So, we want to be sure that we have good coordination and balance in those muscles, which I honestly think functional testing does a really bad job of telling us that. But like a real simple range of motion in those different planes will kind of tell us whether or not, we're having some of these landmines that we're speaking of.
Beautiful. Yeah, and I think I always struggle with that a little bit too with my athletes. Are always asking like, oh, well, what can I do as far as supplementation and things to prevent injury? And I think that's a difficult thing to answer, especially when you've had an injury. Oh, well, should I just start pouring in collagen and stuff like that? But a lot of times that's just lipstick on a pig. To your point on undiagnosed celiac disease or iron deficiency, whatever it might be, like a lot of times supplementation is not the greatest when it comes to not having the answer behind why they have the deficiencies.
No, I mean, I think like what's really kind of, people in certain circles are starting to talk about with the advent of, with all the new peptides and all the things, people are kind of pushing some limits. We saw this with like the Achilles injuries and patellar tendon injuries in NFL last year. And the turf might have been getting blamed for some of the stuff that,
right.
Some of these other things that is not, people aren't readily talking about. But, when people are pushing some of the limits from the nutritional side of things, then maybe they're leaving themselves more susceptible to these tendon injuries also.
I think it's a good conversation to have because, I mean, it's so difficult when you're trying to rush back. I mean, Aaron Rodgers is a great example of that. Like they said that he was ready, but if you look at it, he was actually ready when the timeline was correct. Meaning, that 6 to 9 month mark after a big tendon injury like that is probably the right time frame rather than trying to rush back earlier, because now you're leaving yourself susceptible to all sorts of different things. And I know we're kind of opening up a can of worms as far as return to play and stuff.
Too, this is why, like, you want the right person to do your surgery. I'll just speak from my own experience. When I ruptured my patellar tendon, I didn't know the length tension ratio wasn't right originally from my first surgery until we did an x-ray, and my patella was 11 millimeters alta. So it really, really, I hate to say I'm glad I had the injury because it was horrible, but the one thing I kind of learned was, like, if we're talking about patellar tendon, at least you have your patella, you have bone in the middle of the tendon to see whether or not the length tension ratio got right or not. In the Achilles tendon, you don't have a patella in the middle of your Achilles tendon. So you have all these athletes and you're kind of wondering, why do they never get back? And they probably never get back because that length tension ratio never got right. And that's where, like, these surgeons, they are literally like artists because they have to make a prediction on, once this is healed and recovered. And like George always talks about, he's like, if I had my choice, I'd rather it be too tight than too loose. Because at least with the tendon, you have somewhere you can go with some stretching. But if it's too loose, then it's like trying to take a stretched trash bag and try to get it back to normal length, which is not possible. So as it turns out, who does the surgery is kind of important. So that's why you have like a Dr. Romeo and some of the Dr. Andrews, Dr. Paletta, Alatraj, Allcheck. There's a reason people are seeking these people out for these real specific injuries, because you want somebody who's seen that injury before that is specialized in that area. Meaning, like, if I tore my lat, even though I'm not a professional player, I'm going to Dr. Romeo. I mean, there's just, there's no other way around it, so.
Right. Which I think was interesting too, because he talked about how he will try to force people to have surgery with their at-home doc or stuff like that, just because he's trying to get more people to do the surgery. But it also is quite a conundrum,
Yeah, oh yeah. But if you listen to that surgery on PV saw Dr. Andrews. And then Dr. Andrews referred him back to. So here you have the godfather of orthopedic surgery basically saying no.
Yeah,
go back and let Romeo do this because he's got more experience, in that area. So I think that's pretty telling.
Absolutely.
Yeah.
Yeah. I think it comes back to sometimes when you're trying to find your surgeon, like especially if you're trying to find a connection in your area, like sometimes it's just trial and error. I hate to say that, but you send a couple people to him and just see how it turns out. Granted, you're kind of using one of your patients as an N equals 1 there, but having conversations with him about things we talked about today and what Romeo talks about and Pauletta's talked about and all these different things, it gives you hopefully some talking points to then flush out the people that are doing a really good job. So,
well, and I think one other thing from a performance standpoint would be as creative as you can to train eccentric function of the lat. Because the one thing the lat is, it is a massive decelerator of the throwing motion. And so when these lat injuries are occurring, they're always occurring in the deceleration phase. So one thing I play around with a little bit is, like, if you're in a free motion machine and you're doing, if you can imagine, almost kind of like you're doing a lat pull, like really training the eccentric phase of that. It's so easy, I feel like, to, you're working on a pulling motion and we are concentric of pulling down, but really kind of focusing on that eccentric training part of it, almost to where like when you're doing a concentric pull, that would be a count of 1. And then as you're letting the weight kind of take your hand back up, almost like counting out to a count of 3, and then also training position of the shoulder blade as the weight's dragging you back up. Not to go on a tangent there, but like from a strength training standpoint, I think that might be some good ideas for how to train it, the decelerating phase of throwing. But like we've talked about before, I mean, if you're ever around a professional baseball pitcher when they throw a baseball, it is the most insane phenomenon you've ever witnessed, because you think you're mimicking throwing in your training programs, and then you get around that and you're like, nothing that I can create in the gym can duplicate that. I mean, it's just the most insane thing. So,
yep. Beautiful. Well, yeah, I think that was a good roundabout summary of what we talked about with Dr. Romeo.
Can I add one more thing?
Ahead.
Yeah. So the other thing is, like, when you're throwing a baseball, like if we, went back a million years ago and we gave a caveman a rock, no one from a static position would do the windup that we see in baseball. Like if you can imagine, like you were just going to throw a rock for fun, you'd take 3 steps and throw it. So baseball creates this real, like, artificial situation where you're really putting a lot of isolated forces on one joint. You're unable to dissipate that through the whole kinetic chain like you are, like in, for example, like a javelin throw. Because it's kind of interesting, because the lat tear is pretty unique to baseball. Now, it is skewed because we're throwing a lot, obviously, in baseball, but it's kind of funny that we don't see it that much in other sports, really. So,
yep. Well, beautiful. Thanks, Brett. Good conversation. Go back and listen to that Romeo podcast, guys. I mean, there's so much good clinical gold, not only from the actual lat itself, but also just practice management and other things like that.
He really inspired me on just being a good doctor.
Yeah.
Like he is like really kind of beating the drum on surgeons getting good outcomes, which I've never heard a surgeon talk about that. So I think that it's motivating for all of us. And he basically talked about the crusade he's on, and he said, he's like, I'm getting better and better as I move along. And I just think it's so phenomenal when you hear somebody who's not getting to the end of their career, but they've been doing it a while, and they're not cocky. They understand that it is one gigantic journey you're on, whatever your niche is.
Beautiful. All right, guys. Well, if this comes out, that means we survived our drive to Kansas City.
Yeah, it's telling me to take a break. I must be swerving a little bit.
This will come out afterwards, but we're on our way to the MPI Adjustathon, and it's literally our favorite weekend of the year. We call it the Super Bowl of seminars for a reason. So we hope you guys join us next year and the years coming. I think this is my 10th year now. How about you, Brett? This is
don't even know.
It might be a little bit more than that. So we'd love for you to join us at the next MPI Adjustathon. It's always usually the last weekend in September in Kansas City at Cleveland University. So we'll get to see Carl this weekend, which will be a blast. And stay tuned for a DNS baseball course next year. If you're not subscribed to the Gestalt, I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.